Hello everyone. We'll start with a new topic, epidemiology of meningococcal meningitis. So meningitis is of mainly two types, viral and bacterial. Again, bacteria there is of three types: pneumococcal meningitis, Haemophilus influenza B virus meningitis, and meningococcal meningitis. So meningococcal meningitis is also called as cerebrospinal fever. It's an acute communicable disease caused by Neisseria meningitidis. This is a bacteria which causes the meningococcal meningitis. Meningitis usually begins with intense headache, vomiting, stiff neck, and progress to coma within few hours. Okay, so very serious disease. The meningitis is a part of septicemic process. Okay, from the septicemia there will be chance of meningitis. The fatality is about 80%. Whoever gets the disease, 80% of the people will die. With early diagnosis, the case fatality have declined to 10%. And epidemiological features, agent is Neisseria meningitidis, is a gram-negative diplococci. 12 serotypes have been identified. These are the serotypes based on the structure of the polysaccharide capsule. The majority of invasive meningococcal infections are caused by organisms of serogroup ABCXW135. So this is a serotype which causes the invasive, that is very painful meningococcal infection. And Neisseria meningitidis is a delicate organism. It dies rapidly to heat and cold. Source of infection: the organism is found in the nasopharynx of cases and the carriers. And period of communicability: until meningococci are no longer present in discharges from the throat, they are not infective. And cases rapidly lose their infectiousness within 24 hours of specific treatment. Age and gender: the disease is predominantly the disease of children. Younger groups are more susceptible than older children. Both gender are equally infected. Okay, this is mostly present in the children's. Immunity: mostly immunity is acquired through subclinical infection. Clinical disease and immunization confirms a lifetime immunity. Infants receive passive immunity from their mother. Mother's hemoglobin is there in their body, so they will not be infected soon. And environmental factors: seasonal variation is well established, and outbreaks occur more frequently in the dry and cold months, that is in between December to June. Overcrowding is predisposes the individuals to get infected, that is in a school, refuge and other camps. The people will get infected soon. And mode of transmission: it spreads mainly by droplet infection. The portal of entry is through the nasopharynx or respiratory tract. And incubation period is 3 to 4 days, but may vary from 2 to 10 days. In the clinical course, most infections do not cause clinical disease. Many infected people become asymptomatic carriers of the bacteria and serve as the reservoir of infection. So many people, whoever infected, they will become asymptomatic. They will not show any symptoms and they will act as a reservoir. Meningococcal meningitis has a sudden onset of intense headache, fever, nausea, vomiting, photophobia, stiffness of neck, and various neurological signs. Okay, this is a very serious condition. So brain is affected here, and they will show the intense sudden onset of a headache, fever, nausea, vomiting, photophobia. Photophobia means you cannot open the eyes in the light. Stiff neck, you cannot move the neck, and it is very painful when you move, and neurological signs. And sensitivity to bright light is photophobia, fever, severe headache, confusion, sleeplessness, sleepiness, fits, loss of consciousness, stiff neck, nausea and vomiting, red or purple rash, cold hands and feet, muscle and joint pain. These are the main symptoms. So normal meningitis will be having durometer, arachnoid and pyometer, that is the layers, and in this case they will be having meningitis. That is, infection will spread to the meninges. This is a picture after the infection. The disease is fatal within 24 to 48 hours. Okay, within 24 to 48 hours, the people will die. Even with prompt antimicrobial treatment in good healthcare facility, permanent neurological sequelae may be seen. Okay, there, even though you give the treatment, there will be permanent damage to the neurological system in the 5 to 10% case. So in a meningitis baby, you should watch about tense or a bulging spot, that is soft spot, high temperature, very sleepy, staring eyes, and breathing difficulty, and external shivering, cold hand, vomiting, and itching skin, getting paler, and sometimes there will be diarrhea, pin prick. So these are the certain features you can see in a meningitis baby. In Meningococcal septicemia, there is a rapid dissemination of bacteria in the bloodstream. Okay, from the brain or a meninges, the bacteria will spread very fast to the bloodstream. The less common meningococcal disease is characterized by circulatory collapse, hemorrhagic skin rash, and high fatality rate. Okay, in a certain less common in meningococcal disease, there will be circulatory collapse. Okay, the blood circulation will be decreased, and there will be skin rash and the high fatality rate. Symptom of meningitis in the central: headache, alternating status, ears, phonophobia, you cannot hear the loud voices, eyes, photophobia, neck stiffness, systematic high fever, trunk, mucous membrane, extremities. If meningococcal infection is there, there will be PTK or petechiae. How you can prevent and control cases? Treatment with antibiotics can save lives of 95% provided that the treatment is started within the first 2 days of the illness. Penicillin is the drug of choice here. In penicillin allergic patients, ceftriaxone and other third generation cephalosporin should be substituted. A single dose of long-acting chloramphenicol or ceftriaxone is used for the treatment of epidemic in sub-Saharan Africa. Okay, in African we are using chloramphenicol and ceftriaxone, but here in India we can use penicillin. If they are allergic to penicillin, then we can use ceftriaxone or third generation cephalosporin. Septicemic shock and raised intracranial pressure in meningitis are particular problems in the management of the disease. The most severe condition is the septicemic shock, and the intracranial pressure is increased in the meningitis. In the carrier, treatment with penicillin does not eradicate the carrier state. More powerful antibiotics such as rifampicin are needed to eradicate the carrier state. Okay, in the carrier state, the patient will be having the infection, but they will not show any symptoms. So in this case, you cannot give penicillin. You should give the rifampicin. And contact cases, close contact are at risk of developing the disease. Antibiotics are effective in preventing additional case through eradicating carriage of the invasive strain. Antibiotics can be given here. Mass chemoprophylaxis. Mass chemoprophylaxis is restricted to medically supervised communities, that is healthcare community people. The drug of choice is ciprofloxacin, minocycline, spiramycin, and ceftriaxone. These can be given to the healthcare members. And vaccine. Currently available meningococcal vaccine include polysaccharide vaccine and polysaccharide protein conjugate vaccine. This can be given to prevent the infection. And polysaccharide vaccine, internationally marketing meningococcal polysaccharide vaccine are available in bivalent, that is A and C vaccine, and trivalent ACW135 and quadrivalent ACW135Y formulation. These are the three formulations available in the polysaccharide vaccine. The vaccine contains 50 microgram of each of the individual polysaccharide. The vaccine is administered as a single dose to person more than 2 years old through subcutaneous route. Okay, through subcutaneous you can give this vaccine. Adverse reaction to vaccine are usually mild. The most frequent reaction is 1 to 2 days of pain and redness at the site of injection and transient fever. The conjugate vaccine, it is a licensed meningococcal conjugate. Vaccines are monovalent, that is A or C, or quadrivalent ACW135 and Y, and also include a combination vaccine based on Haemophilus influenza type B and Neisseria meningitidis serogroup C vaccine. These are the combined, that is also called as conjugate vaccine. This is a vaccine looks like. Conjugate vaccine should be given as an intramuscular injection, whereas the previous vaccine was given in the subcutaneous route, but has to be given in the intramuscular injection, preferably in the deltoid muscle. Meningococcal vaccine should be stored at 2 to 8 degrees centigrade. Conjugate vaccines are preferred over the polysaccharide vaccines due to their potential for herd protection and increased immunogenicity. Okay. Conjugate vaccine, that is combined vaccines, are more preferred than the polysaccharide vaccine. So that's what about the meningococcal meningitis. We'll see in the next chapter. Thank you.